best practices of implementation of Ebdm in the states. Sir, please come. Once again, my warm welcome to all the dignitaries on the dais. And I also welcome all the participants in the hall and special thank you that you have taken a time to attend this session. This session will focus on best implementation practices in the states for Ayushman Bharat Digital Mission. Let me first give a brief introduction of all the panelists and the chair. So this session will be chaired by Mr. Ghayasuddin Ahmed sir. He is 2000 batch IDAS officer. Sir is currently financial advisor in National Health Authority and has extensively worked in Ministry of Finance as well as UN missions. We are joined by Shri D. Randeep sir. He is IAS batch officer of 2006 batch and he is currently Commissioner of Department of Health and Family Welfare Services in Government of Karnataka. Sir has extensive knowledge of implementation on ground of the schemes. We are also joined by Shri Naveen Kumar sir. Sir is from IS batch 2007. Sir is Special Secretary to in Health of Digital Implementation and Hospital Administration in Government of Andhra Pradesh. Sir. We are also joined by Dr. Manan Akhtar sir. He is Special Secretary to Ministry of Health and Family Welfare and State Mission Director of Ayushman Bharat Digital Mission in Uttar Pradesh. And Shri Anshul Agarwal ji, he is State Mission Director of Ebdm and Additional Chief Executive Officer in Bihar Swasth Suraksha Samiti. So I'll just give a brief context of this session. We have already seen in the sessions of the earlier day that an open, interoperable as well as scalable digital infrastructure has already been created in the country. We have also seen that this digital framework has taken a huge amount of data and is scalable across the country. Now this next step goes upon adoption of these digital registries, their population, and then creation of digital health records, their linking as well as sharing. Currently, we are having more than 1 crore digitally linked health records, special thanks to Government of Andhra Pradesh. And then in this adoption strategy, states will be the main and the most important stakeholder in creating this digital health ecosystem. And therefore, this session will focus upon the best practices that the state have done or about to do or planning to do, which will increase the adoption of Ayushman Bharat Digital Mission. Therefore, it will be pertinent to see that what are the do's and don'ts and what works successfully in implementation of this mission. This mission is complex and but is also revolutionary. And once we implement it successfully, I think states can, come together and see that in this atmosphere of coordination, we can give the benefits of Ayushman Bharat Digital Mission to all the citizens of India. Now, I would like to call upon chair of this session, Ghayasuddin Ahmed sir, to give a brief introductory remark about this session, sir. Sir.
Good morning, everybody. Good morning. I welcome you all for this first session of second day of Arogya Manthan. I welcome my fellow panelists also for this session. I'll start this session with the words of the CEO with regard to Ebdm. He says that highway is ready, we need to ply vehicles. In this regard, the implementation and adoption of Ebdm, the most crucial role is that of states. This is a central sector sponsored scheme and is being 100% centrally sponsored with regard to funding and being implemented by the states and UTs across the nation. This session is important to the extent that we are going to deliberate that after rollout, how far we have come, what are the bottlenecks, what are the best practices so far the states has come out. I have some list in which some of the states has done relatively better, like Andhra, they have done exceptionally well in linking the health records. Karnataka has also picked the pace for population of digital registries. Bihar is also working very hard to populate the registries. West Bengal has linked this, integrate this HMIS solutions. UP has also populated the HFS data. During the discussion, I think the state's mission directors will be presenting their achievements, and we will be discussing those after this, at the end of this session. At NHA, what are those practices which can be replicated by other states, or what are the policy guidelines which need certain changes, because at NHA level, we issue guidelines, we take feedback from the states, we have our own ways of getting technological feedback, how to best implement this project. It's a very ambitious project. I would like my fellow panelists to concentrate what are the strategies to various challenges, the capacity, especially the capacity building, and the fund management, and when there is a change management of stakeholders, the manpower, and what they expect from the NHA in terms of technology, in terms of incentives. Recently, we also came out with financial incentive packages for the states, where the performance on the district level also being recognized, state level also being recognized. And the most important thing as of now, what I understand, is the population of registries. These are the building blocks of this Evidium. So it would be better if we concentrate more on population of these registries to go ahead, how to go ahead, what are the problems, and what would be the solution in their opinion. I think with these remarks, I open this discussion to my fellow panelists. Thank you.
Thank you, sir. So let me first call upon D. Randeep, sir, to give us a presentation about the progress of Ebdm in state of Karnataka.
Good morning to one and all. Let me at the outset thank NHA for having invited the states here, especially Karnataka. We are represented by our Assistant Secretary Health, Government of Karnataka, Mr. Evidium, and myself, Mr. However, when it came to the health facilities, the professionals, and the So 10th June, the state appointed the SMD and I could take charge. Thereafter, it took a good 1 month for us to kind of put teams into place, because one thing about Karnataka is we never really immediately went into the outsourced model. We believed that the state teams, the district teams can themselves drive this if ably motivated and if the objective of Evidium was kind of informed to them. So 14 July, we had the nomination of the joint directors, and really it was mid of July that we actually pushed Abdm in the state of Karnataka. So that's, the journey is about 2.5 months long. So journey till date, if you look at ABA per se, what were the challenges that we kind of encountered? We looked at, I mean, people started asking us, what are the benefits of ABA? Why not just have a virtual ID? Why do you require a health ID and a card, etc., etc.? What will you do with multiple IDs? You have PMJY card, you have Aadhaar, you have ration card, and now another card over and above this. These were the queries, but largely they were disguised forms of reluctance and resistance to adopt this. What did we do? We took up intensive IEC. We started telling people this is a unique health ID, just like what Aadhaar is for everything else. For health, it will be ABA in the coming days. We did stakeholder workshops. We had to involve the IMA, IAP, FOXY, all these associations by word of mouth, then went on to say that yes, this is a national program, this is something that is futuristic in nature, and we need to involve ourselves. We also stressed ABA through our existing portals, the e-hospital, RCH portal. Thankfully, all of these are, en route to being Ebdm compliant, so it was that more easier to get them on board. Even the private partners like Paytm. And very recently, we have also started this drive for the new co-branded PMJY cards. So with ABA also automatically getting generated along with these cards, that helped push the numbers in ABA. When we come to the health professional registry, again, lots of challenges from our own doctors, nurses, who said that this is voluntary, why should we get involved? The ones that who tried to actually log on, there were session timeouts. There were some delayed approvals from the councils. People started asking the benefits. What is so great? We got a state ID number. We have our own registration number. So why would you require one more? So there was slow uptake. There was denial sometimes. So we really had to crack the whip when it came to at least the government professionals. So we mandated it for all government health professionals. We told that absolutely there is no choice on your part, and that is why we could push the HPR numbers. We had multiple stakeholder meetings again. We had a telemedicine platform through which again many of the stakeholders were linked, doctors, nurses. We got them involved. We recruited close to about 5,000, 6,000 CHOs recently for the health and wellness centers. So we started getting them on board also. So these were few of the strategic kind of initiatives that we took. There was a lot of follow-up through WhatsApp with how many got registered, how many not. And because of the continuous follow-ups, orders, and review meetings, we could fairly achieve the target that we set out to. When we came to the health facility registry, the primary opposition among stakeholders was, again, it's a voluntary option. Is it going to maintain transparency? The stakeholders were worried about privacy issues, HR-related and logistic issues. So really, we needed to, again, work hard on this aspect. First phase, we thought the low-hanging fruit was obviously government facilities. We have close to almost 3,000 facilities up to the PHCs, and again, if you look at another 8,000 odd sub-centers. So we thought, let us try to push these facilities on board first. These early reaping of benefits kind of reflected that the government had the intent to push HFR in the state. So we had slow onboarding of the private hospitals and the clinics also coming in. The state has a private medical establishment act, which we which we used to issue certain mandatory instructions saying that hospitals, clinics, where kind of encouraged to come and register themselves here. The State Health Authority, of course, we said that all empaneled hospitals with the State Health Authority have to mandatorily have a health facilitation ID. And this is the ID, the health facility ID, and this is the ID with which they would be recognized in the overall PMJOI system. So that kind of integration once we bought, we had all the private empaneled hospitals jumping on board and said, yes, we will come up and register. So these were certain techniques, methods we used. Of course, we requested that the NHA be much more firmer in its directions, and we've requested them if some kind of a mandate can be issued to all the private establishments to come out. That makes the state's work that much more easier. Of course, there were written and oral communication to all the associations, organizations at the state's end. We involved FANA, the medical college associations. We have the KPMA associations. Slowly, they're turning the tide. I'm sure in the coming days, we would have almost all of them on board. Personal health record. So the first three obviously involved just registration, and this is where we showed what it could actually translate into. So we started reaching out to patients who came to our hospitals, government hospitals again, the medical colleges, and actually told them that if your health record is actually linked to your ABA, and Karnataka uses the NIC's e-hospital portal to a large extent, and the minute we linked these records, people started seeing their benefits. We also told them that in the coming days, be it their prescription, be it diagnostic reports, to an extent we have started online registration also, pre-registrations. So all this kind of helped convince people, patients who landed up at hospitals to enroll themselves for the personal health record. Of course, we have respected consent. Nowhere anyone was forced against their consent to link their records, so that prior consent was taken, and then it was done. So we did a lot of social media campaigns, even at school level, college level, and mass gatherings. We never missed out on an opportunity to talk about these 4 parameters. Interoperability and its benefits were explained. It could be seamless, whether you're visiting a private doctor, a government doctor, your records could be shared across the portal. So once the future was told to them, what it would be like, we found that it was that much more easier to get more enrollments. So this was the outcome. 2.5 months later, Karnataka stood at 85 lakh ABA. Of course, ABA, we would have liked to do much better in ABA, but in the coming days, we're going to really push for it. But this is what really changed. I mean, our verified health facilities jumped to 22,084. We stand second in the country. 22,528 verified health professionals, again, second in the country today. And health record linked, because Andhra took that huge lead, we ended up at second place. But still a respectable 122,000 records kind of linked. And in the coming days, all these three are going to saturate, and we're going to ensure that we reach to the maximum extent possible. That again is the dashboard showing where Karnataka stands in the 4 parameters. So the way forward, and this is my last slide. So how do we sustain the momentum? It's always easy to give it that big push, but once you reach 70%, 80%, how do we ensure that we actually saturate and ensure that all are covered? So one is, of course, empowering the citizens for generating and utilization of ABA. So this is something that we need to tell people that they really don't need to come out somewhere and get their ABA done. It is at their fingertips, more applications, more accessibility to create ABA. As I said, if a directive from NHA could be issued, it will be excellent to have private health facilities and health professionals on their own coming up and registering, because this could be a national directive in terms of getting them all on board. The Ebdm compliant HMIS, if we could have many more HMIS systems in the government and private talking to each other on a common platform. As the chair had mentioned, the highway is ready, the interoperability is ready, but it's just that the systems have to now plug in so that there is seamless exchange of information across these platforms, and of course with the consent. And then, only sky is the limit once you end up doing that. Of course, the facilitation, creation, and utilization of longitudinal health record by the citizens, professionals has been amply explained, and this in coming days has to be pushed up to a rapid kind of an IEC campaign. And lastly, we are looking at a customized e-hospital. We have requested NIC to kind of customize it to the requirements of the state, and we are working with them to ensure that any kind of registration under Ebdm becomes much more seamless and much more transparent, so that the numbers could increase in the coming days. So that has been the journey of Karnataka till now. We thank the support of NHA. They have been always there to guide us in terms of how to achieve our targets. But now the ball shifts to the phase 2, where we start consolidating our achievements and also ensuring that the final objective of Evidium is met, which is basically linkages, interoperability, seamless movement of records. So I think we are well poised to achieve that, and looking forward to hearing from my fellow panelists the best practices in their states and take up those learnings. Thank you again.
Thank you, sir. This surely has been an exceptional journey of Karnataka with a small period of 2 months. One of the most interesting things is that the WhatsApp group that we have with the team Karnataka is the most interactive one. And yes, sir, and one more thing, sir, as you mentioned about mandating it, I'm happy to tell you that in the last meeting of Mission Steering Group of Evidium, many of our adoption proposals in the MSG have been approved, and we are surely thinking of coming up with a guideline of mandate of Evidium in different government programs and the government facilities, obviously in a staggered way, because every person or every facility is not at the same level of digitization. Sir, now I would like to call upon Naveen Kumar, sir, for give us a presentation about Evidium journey in Andhra Pradesh.
Thank you, Akshay. So I think when Sir joined as Commissioner Health for the first time, I think we were sitting in his office, Randhi sir. So what we did is, when this objective was given to us to implement the Ebdm in the state of Andhra Pradesh, we went on to other states. And we learned. I think Karnataka was already in a better stage implementing e-office and all. So questions we asked was, what went wrong? So that's the first thing which we always asked, what went wrong? So that's where you will start your learnings, right? And we built our entire journey. I think when we started our journey, so this is the mission. So I've also added this health researchers. So one of these things, why I'm talking about health researchers, when we started making these records, we never had an idea what this would mean actually. We were doing it as just another government scheme, right? Somebody told us from the top, then we started doing it. The doctors came back to us, the professors, the assistant professors, and the medical education department came back to us telling us, now lot of research can happen in the country because there is electronic record is available. So that's the, I think I would call it unintended consequences of what, I don't know whether NHA had foreseen it. For me personally, it was something which I learned from the doctors. So this is our journey. So we started somewhere in October 2021. As soon as it was launched in the country, I think September 23rd, 2021, it was launched in the country, and then we started doing it. All our application from the day one had been Ebdm compliant, which means that we had a vision that everything we do should benefit. It's not just you're doing it as a scheme, right? So we always understood that the record should be available for the patient. So this patient-centric movement or patient-centric digital movement had taken off, putting the patient first. It's not just like any other digitization, the initiative of government. It's putting the patient first. So the patient is available, and the records are available for the patient. So that's how we started doing it. And we also rolled out NIC e-hospital. I think we learned it from Karnataka. We also took doctors to them. In fact, one of the successes we had was taking the doctors to each of these facilities and showing them how doctors themselves are feeding data into it. So that was one of our biggest success, right? And we also took doctors to Narayana Hirdalaya. In fact, we were able to see, I think Praveen sir told us to see all these facilities. So we could take our doctors to these facilities and show them this is how doctors are doing. So, and I think we use this psychological principle, seeing is doing, right? Or seeing is believing. So we wanted to tell them or not push them by, putting a memo or something, taking them across many institutions. We took them to Continental Hospital. The director of Continental Hospital himself logged into a computer and showed us. the Adyar Cancer Institute. So we were able to take doctors to each of these institutions, create that kind of ecosystem or change behavior so that they could adapt to this behavior. And we also have our in-house doctor care team. In fact, why we call it doctor care is we also learned from one of our integrator called Eka Care. I think they are also put a stall here. They told us that they also did their market research. They were telling us 105 records. As soon as the number is 105, as soon as a doctor enters 105 records, he is very comfortable in using a system. And how does a doctor benefit from their system? The doctor benefits from their system is he is able to tell, or he or she is able to see where their patients are coming from. That would help them to geographically set up their own clinics. Oh, that's how, see, you have to sell something to them, right? It's not just you're talking about EHR, which would only benefit the patient. How would a doctor benefit? So, and even given a government system, you get only 2 to 3 minutes for a doctor to examine a patient. So how much we can do more EHR, give the doctor a good background to what he is going or what he is going to ask. So that would give them a better understanding of the patient to give better treatment. So, and right now we have rolled out, I think we are rolling out in all the CSCs, our eNIC, and we are also looking for, launching the next gen hospital in our hospitals. So I think we are already the largest in terms of ABA creation, 34 million ABA IDs. We have almost, and I think one of the lessons which we are showing to the country is government hospitals, government doctors are leading this Evidium. So we are putting a very clear message to the people that we are the ones, we are doing what it takes to deliver. This is something unbelievable, or you would not believe that government would do this, right? So we have taken it a point to show government will do it first and to tell what private will do. So that's what we have pushed this agenda very clearly, that all our government institutions, time and again, we are teaching them, we are coming back with feedbacks, and we also take their feedbacks. In fact, we also sit with them to see what is their turn. We also see what is the time taken to enter a record. So in fact, I remember one of our earlier research we were doing, what is the time taken to register a person? When you go to, I think, sir, we were in Chikbalapur when we were doing this one, and there's so much expertise, they were able to do 30 to 40 seconds is the registration of a patient. I had just put my timer to see what is the time. So this is how, when you build systems, we had to go to that smaller technicalities, which would help building the system strongly. So this is the e-hospital where we have put it in so many facilities. We have 12 modules comprehensively done. I think we are also systematically, and for each of these modules, we have a program leader within the institution. If you see, one person cannot lead the modules inside the organization, maybe an hospital. So each of this, so we have trained each of the modules for a program leader. There's a program leader within the organization. They have to sit together, talk to each other. So this is our doctor care app, which is rolled out in all our PSCs. So we are looking at, you can also see when we did our urban PSC 552, we could easily roll out in 1 month. I would say that we could roll out in within a month. But if you look at our rural PSC, it took 1145. There is a reason behind it, because all of our younger professionals are in the urban PSC, so where it was easy for us to push it, get it going. But and also if you see, I am not putting the records which were generated. We also have a system, if you see our dashboard, which will clearly tell how many institutions are there and how many institutions have entered records. And the records are not entered, either our call center will call them, why is there a problem with your system, and we also see on a weekly basis, and we also see whether these people are entering record. So also we started doing our inspections across the facilities. So they will go and sit with them, see how many OPDs did you see, how many OPD entries did you make in our system. We learn, I think that was the most important point. There are issues, there are teething issues. It's not just the doctor doesn't want to enter it. So there are teething issues, why they are not able to do it. So we learn from each of them, and then we come back and correct it, because one of our application is sometimes it gets slower when you are going, then it is network based, so it gets slower. So we also think of how can we do this? Can we reduce our coding? Can we, instead of putting a yes or no, can we put an alphanumeric coding? So that's how we sit and enhance our system. So this is one of the things which we do. Any person who comes to our lab, their lab details report goes to their mobile phone automatically, which is like any private organization which does Pathkind or anything. So this is the login of a doctor. We have screened them. This is how our doctor care screen looks like. So when you look at it, we have pulled data from our NCD survey. We also pulled our data from Arogya, which is, if you can see this data, which is from 2022, 2019, 2018. We are able to pull records from the older records which are already available with the government. So these are digitized data. I'm talking about digitized data which we are able to pull. We also pulled data from 104 and 108. If anybody has operated or used our 104 or 108, we also pull data from that. So when the doctor is able to see everything at a screenshot, and he can make his own judgment, and this is forever. I think yesterday when the CEO of NHA was talking about it, these records should be available for everyone to look at, for themselves to consume, right? And I also look at this vision, every single child who is born in the state of Andhra Pradesh would have his or her record forever on the digital platform. That's what we look at. So this is the record. So there is a difference. This is a digitized record which we have pulled out from our Registry. So these are the X-rays. We can also take a clear look at it in case if he's going to orthosurgeon, he can not have to carry the bunch. We have already done this with our systems. This is something which we are experimented in the last 1 week. We are able to capture our ECG on our, this is our system, doctor care system, the record is there. We are just able to capture ECG. We are also working on, how can an AI, for a use case, I could mention this one. These are ECGs which can be picked up in the rural PSCs, right? And then maybe a tribal or a very far away rural PSCs where a cardiologist is not available. So what we can do is these data can be read by an AI tool, right? And then the AI tool can, pick some ECGs which are abnormal and send it to a cardiologist. Instead of cardiologist seeing all 200 data records or 300 records, what he would do is he is able to just pick those records, 20 or 30 of them, which would be useful. And we also, reduce the time. Also what we could reduce the time efficiently because the cardiologists are less in number. So similarly, we'll be able to pick many diagnostics. And I'm told that digital diagnostics is the future of healthcare. The future of healthcare would be two. One is digital diagnostic and the home care. So how do we build our systems for digital diagnostics and the healthcare? That is going to be how we define Evidium. I think if you ask me what is the future of Evidium is, are we able to give services at the doorstep of the person with the help of digital diagnostics? So this is one of the things which you also pulled out. And we also have this questionnaire which goes to them, and we also do this when you see that what is the time, we also pick the meta details of the login processes to see whether it was properly used or not. So that is something which we keep on learning from them, right? So it is very important when you make a patient-centric Ebdm system, put the patient as a boss, and he will or she will help us to better our systems. So, and we are also integrating our blood banks. I think yesterday I saw some Paytm people who also have a software to integrate blood banks. The philosophy which we learned from the COVID success, I think that's led by the NHA, that you should be able to share information in a useful and secure way that can be used by others for the betterment of others. I think during the panel discussion yesterday in the second half, Sir was talking about it. Digital healthcare means we should not put digital first. It's the healthcare which is first. So that's how we start our journey. I think Abhishek sir also was mentioning it. And what we also did is, we wanted to make it competitive across the board, right? So how do you get your doctors to, you have to create that community feeling, that competitiveness amongst them. So we also started felicitating our doctors. If you see this doctor who is in the center, he's my oncologist. He leads the biggest hospital in Guntur. He had personally, I'm talking about a single doctor personally entering thousands of records by putting the older records. If you go to if you see his login and open and see it, there are records which he has copied from 2013, 2014, and he believes this would help the patient. Cancer records, nobody bothers about, but he has started doing this. That is the kind of motivation we have put amongst people. It is important, very, very important. If this journey has to carry on, I think what NHS is doing it, we should take every single person. In fact, we also started felicitating our DEOs. I think that guy is there, is a DEO, data entry operator. So this is a team, right? It's not about the doctor, it's not about the nurse, it's not about the program manager or the leader on the top. It's the entire team. The DE also contributes. If he's able to log in fact, when he started in Kakinada, there was a long queue, right? So Kiran called me and asked me, do we have to do something about it? But in a couple of days, they were able to, redress the solution because they were able to learn typing it faster, and thousands of, every single day, my hospitals at Vijayawada, Guntur, they log in around 2,000 to 2,500 patients a day. And we are able to register each one of them. So that's it. Our journey has been good. So we look forward for a better, longer journey with Ebdm. Thank you so much.
Thank you, sir. Me being doctor myself, I understand, sir, the data can really support in decision making of a doctor, sir. So now I'd like to call upon Manan Akhtar, sir, from the state of UP. He's to give us the practices that are being followed in UP.
Good morning, everyone. Good morning, the panel alongside with me and everyone who is present here. So, Uttar Pradesh is the biggest state in the country, and we usually take a bit of lag to do things, but once we start, then we move ahead very fast. But this mission has been in the state only for 3-4 months only. But we have been moving ahead. So what I'll like to do is that in health facilities, our state has done a very good job. And after health facilities, I'll go how we are going to populate our HPR, and then I'll explain what is we are thinking in the future for what we want to do. So as you can see that during the time of COVID, we went out along with our partners UPTSU to all the sub-centers, to district hospitals, all the special hospitals, and we got all the data which we needed to display it for the use of the public. So that anyone who is in a nearby area, it's like a kind of Google map. They can use UP ke Swast Kendra, which you can see, and they can go to the nearest health facility possible. So in the last 1 year, with the help of UPTSU, we created an app, and we got all the data, including the geolocation by a field survey, and the CMOs helped to verify it, and then we got all the data which was needed to have a geolocated sub-center, PHC, CHC, district hospitals. So we had this data in last 1 year from with us from before. So once we went into the HFR, Health Facility Register, so you can see the comparison between what we had from before and how the Ebdm HFR architecture works. For Ebdm HFR architecture, you will need to generate an HPR ID of a health facility manager, then search the health facility, register it, and then review and send it for verification to the NHA, which would have taken a lot of time. So we started to talk with the NHA, and we told them that how we already have the required data with us, and we don't need to double the work which was being done. So NHA, they helped us, and they learned, so we created an API which would be interacting with the UP ke Swast Kendra app and the data and dashboard we already had. And the important data which was needed for the HFR was already present. So we went for a bulk upload. We used a state facility manager, and we created a state verifier which was specifically done for the state of UP. And by that, we bulk uploaded the data. And once the API interacted with each other and the data was harmonized, we got back all the HFRs with us. And now we have all the HFRs with us already existing with, that's why we have the highest number of HFR, around 28,700 today. But that was just for the public sector part. We are also working using the Evidium HFR architecture for the private sector also. And we are using IMA plus other stakeholders. And as I was saying in his slide, that clinical establishment is a very good tool because you already have a lot of data in Clinical Establishment Act. So you use it to, and UP has also adopted the Clinical Establishment Act of the central government. So we use that data also to interact with our private entrepreneurs and private hospitals to get the data created for the HFR of the private facilities. So we are working on the health facilities in this way. But since government is creating new health facilities every time, like everyone who is in the government will know that every year now we are creating around HWCs, which will be around 5,000 number. Basically, sub-centers are being converted into health and wellness centers. So now we have an API which is continuously there with the NHA data. So as we enter the data in the UP ke Swasth Kendra, it interacts with the API of the NHA and it gets uploaded in the HFR, and you can see the HFR of that data, of the center. So that is how we are creating the HFR architecture with us. And we are moving ahead with this along with our private facilities. So next, what we are planning is related to the HPR. I'll talk about the issues later. So as we all know, who are in the state government and the central government, that we already have the data of all the health facility workers with us. Basically, right now we are using only the data for the nurses and the doctors. In Manav Sampada portal or the human resource management system, we have the data already with us. As you can see, I'll put it again forward so that you can see the what is below the iceberg. So in the HRMS, we have the personal information of every employee who is there. And we have, since we have created the HFR of all the health centers with us, and those HFRs are linked with the Manav Sampada, because if I'm working in a sub-center as a doctor, not as a doctor, I will say PHC as a doctor, now I have the health facility record and it is already present there, and you know that I'm working there because in Manav Sampada it is reflected that this center is, this person works in this hospital or sub-center, whatever. And we also have the registration number, like every doctor will have a registration number or a council number. So we have this data from with us from before, which you can say is like, we don't need any preparation for that. Government has been doing it for a long time. So what we are trying to do, and we are interacting with NHA with, on this thing, is we are trying to create either through web. If we are going for the web, then the doctors or the nurses will, what they will do is basically will create a platform where they will go and log in, and they'll get an OTP, and then it will be sent to the NHA, and NHA will provide an ATP, and you'll have an HFR, HPR. But there are other ways of doing it also, which are easier ways. Since we have HRMS data with us, we are thinking of creating an offline. There is an issue with the web one, which I'm telling you once. I'll tell you the mobile one. So we are thinking of creating a mobile app for all the professionals. So once the professional will have that app, he will give their Aadhaar into it, and it will be an offline app, because for doctors in the urban areas it is okay. But if you are thinking of the nurses working in the rural area, then you need something which will work offline also, and which can give bulk data. So once we are interacting with the NHA, NHA gives us that we'll make a web app, an offline app, in which already the Manav Sampada data will be there. If it is not there, the doctors will fill up whatever is not there, basically their Aadhaar number only. Because rest of else is with us. They'll fill the Aadhaar number in offline mode, and once the Aadhaar number goes to the NHA will verify the data, and it will come back, and you will have a healthcare professional registry for the government sector, 100% without any extra effort. So that is how we are planning it. But since yesterday also you must have heard what Vasant sir was telling, Vasant sir, in the interoperability part, we are trying to move in a direction in which all the interoperability part are present. So once the HPR is created, right now we are creating it only for doctors and nurses. But that is not going to work for the public health in India. That is what in UP we believe. And so what we are requested with NHA is to have us create HPR for everyone. Everyone will include every health facility provider, including the ASHA, to up top. Because if we want interoperability, then we need to do that. So basically, HPR is created, and it is interacting with our medical education institution, the health facility registrar, and the national bodies, and it will keep getting on updated as we move ahead. So this is the progress, how we are doing it, but this is not the bigger part of it. What the bigger part of it is, and as Vasant sir was telling yesterday, that what we want is interoperability and the use of the data for public health. Public health is as important as the individual health. So yesterday you must have heard when Ashwini Vaishnav sir was speaking as a keynote, he told that in Eastern cultures or the Oriental cultures, family is very important. So just having an individual's HPR, EHR is good for that individual. But when we talk about public health and its larger impact, we need the geolocation, plus we also need to work to provide like IDSP, etc., infectious disease, NCDs. So what we are thinking is once we get a permission for ASHAs and others to be registered also, we'll get them registered to the HPR, and then we would like to go in a process of family ID rather than going for, we'll obviously have a personal ID also, it's like personal Abha also, but we'll also look for a family ID. And the family ID will be enumerated by the ASHA. And once the ASHA moves ahead and creates a family ID, what you will have is basically every family, and ASHA is doing this work. ASHA has to enumerate every year. They have to create a line list of pregnant ladies, the children who are due with vaccination. So they are doing it every year, and we are giving them incentive for that also, but they are doing it on paper. So once we have this opportunity for the ASHAs to do that, we have already provided them mobile app through NHM for other works. So once they update it, we have a family ID in which now what she has to do is, if anyone gets pregnant, she just needs to put in that this lady is pregnant. She will start to have all the data, and like the HWC will start to have, Health and Wellness Center will start to have, okay, there is this lady who is supposed to have ANC on this date, this date, this date. So there is no need of creation of a manual line listing. If there is a children born and ASHA fills it up, then suddenly after 45 days, that family will also get a message, and the ASHA or the NM will get a message that this boy or a girl is due with a vaccine, please get it done. So this will be the base. And this base can be used for your, since it will be geolocated, it can be used for other things also. Like supposedly I'm working in a CHC as a doctor, and suddenly I start to see that 10 people have come with dog bite, or 10 people have come with diarrhea. And I want to see whether this is an incidence of an outbreak, or is it just coincidental. And when I see the geolocated data, and I see as a health expert or as a doctor also, that this village, there is the number of diarrhea is very high compared to other parts. That means that there is some kind of pollution or some kind of intermixing of bacterial or contaminated material to the water, drinking water in that village. So as an MOIC of a CHC, I can work with other departments and tell that, okay, there is a problem in the drinking water here. Maybe we can reduce that, and suddenly we have a solution for, instead of going for individual person, we have a solution for a bigger thing. So that is how UP is planning it for the future. And I think NHS interaction, we are having a lot of interaction, and we'll try to find out how to move ahead with that. Rest of it is, I think, concerns. Everybody knows only what are the concerns, but when it comes to HFR, there should be some guidelines on how the district verifiers are supposed to move ahead. It's not there. We need to be having more training session and hand loading of the states. Once we create a Ebdm, basically we have how and the number of people who are to be taken in. But to take in people, you need to have a structure in the state government. A state government is not going to take in somebody without creation of the post, or without creation of, without the sanction of the cabinet. Because after 4 years, if the scheme stops, what will happen to those 50, 60 people which you have hired? And the finance department is not going to encourage these kind of things until unless you have a cabinet approval. So that is something I think which NHS should work and interact with the states and try to make it easier. There are multiple digital solutions. I think on this interoperability part, we have been working. Silos, and last part which I've been interacting with sir also. I've been lucky that the person who's looking after finance is here. We have interacting with him that this is not going to be a 5-year thing. this is going to grow and this is going to grow big. So how the fundings will be there after 5 years and how the funding should be for the next 5 years also. Like if we hire 50 people today, the funding structure is like a normal bell curve. So it is increasing on third year, it is going to be 6 crore, but for the next, after 2 years, it is going to become 2.75. So if I have hired people who are getting 4 crore per year, after 2 years, we are going to get only 2 crores. So, but for the whole program of 5 years, we are getting 20 crores. So we should plan it in such a way that once the professionals are hired, they can at least go on for 5 years. They should not have, the state should not have an issue ki for the first year we are going to take a supplement from the state government. For the last year also we are going to do the same. Because central government usually, if we have not utilized the fund, doesn't releases the fund in the coming time. So that is all what we are doing and we are trying to do and what help which we need from the NHA. And thank you for calling us here and giving us a chance to present our side. Thank you.
Thank you, Manthan sir. Now I would like to call upon Anshul Agarwal ji to give us a background of the Ebdm in the state of Bihar.
Good morning, everyone. I am Anshul Agarwal, representing Bihar as State Mission Director Ebdm. I am also accompanied by my colleagues who have worked very hard for this achievement for which we are here. I have a short presentation which will be presented. So this is the snapshot of Bihar. So we stand at rank 1 in populating professionals registry. We stand at rank 3 in creating Aadhaar IDs. Obviously, major chunk for creation of Aadhaar IDs is from CoWIN portal. We stand at rank 5 for populating facilities in the system, which is almost 98 to 99% of total government facilities in the state. We also have a HIS and EMR provider on board. We have a contract which has been signed with the provider on 6th of September. The key achievement of Bihar has been populating professionals in the registry database. So we were very clearly guided by the NHA about the objectives which should be, which were expected, about the process and about the approach which was expected to be followed. And following that, we clearly issued a letter which was duly signed by Executive Director, State Health Society, sir. And we clearly laid down the responsibilities of the district program managers. He was made the nodal officer for implementing this HPR. And also from the very initiation, from the very beginning, we were clear that head clerk of the establishment section from the civil surgeon office needs to closely be involved in this machinery. So I'm talking about these kind of letters which were issued from the Executive Director SHS. We clearly mentioned that this has to be done in a due time frame. We clearly mentioned that we are going to felicitate the good performance, and we also clearly mentioned that the non-performance may lead to strict action if not done within a time frame. So this slide also shows the communications which were done regarding Ebdm. So we had 2 communications regarding facility registration, and we also had 3 communications regarding professionals registry. We sent frequent reminders letters. We conducted regular VCs. And also, we clearly identified the districts which were continuously non-performing and pinpointed them in our VCs, and that ultimately led to the achievement. So what I'm speaking is this: civil surgeon of Madhubani district in Bihar issued a letter from his end indicating that all professionals have to register themselves on an immediate basis, otherwise their salaries might be stopped. So I think these kind of initiatives and these kind of interventions ultimately led to us populating professionals in an expedite manner. So this is a snapshot indicating the support provided by the development partners and also our other officials. So in one council, nursing council, we had pendency of around 15,000. So we deployed additional 10 resources who worked through the physical database, which was very old, and provided all kind of support that was needed for council verifiers, so that the process could be expedited and we could achieve. So this was the VC which we did regularly. We provided all kind of infrastructure support also if laptop and other things was not there. We also held regular trainings, including both physical and virtuals in the district itself, the districts which are not non-performing. We held trainings with block MOICs and block data entry operators also, because we believe that due to infrastructure issues, internet and everything else, professionals registry may take certain amount of time. So we were very clear that the camps for professional registries should not be conducted in the districts, and the block officials should be very well equipped for registering professionals. So we prepared accordingly, and our teams went extensively through the districts and also connected with the blocks. And ultimately that led to populating many professionals in a quick span of time. So this was our daily tracker which we used. We clearly pointed out the districts which had low submission against the target, and also it indicated some districts which had adequate submissions against the target. So this was our journey of HPR population. So we can clearly see whenever we had a VC or whenever we issued a reminder letter, there was a steep spike in the progress. So for example, on 17th August, we had only 5,734 professionals that were registered. But within a quick span of time, on 26th August, the population registry got almost doubled. And it was only due to a VC and the clear directions which were given. So these are some of the steps we undertook for registering facilities. So for registering facilities, we made DM EO as our nodal officer with adequate support from the civil surgeon office. We again issued letters with our clear intent and clear approach that was needed. Adequate support was also provided from NHA. NHA representatives came down to Bihar, and they went to Muzaffarpur district, which was also a pilot. So we provided all our resources in the Muzaffarpur district to begin with. Thereafter, we got to know the challenges, and thereafter we got to know the approach which should ideally be followed. And then we, in a quick span of time, after exhausting and saturating Muzaffarpur district, we quickly spiked it, and quickly, within a short span of time of around 1 month, we began on 29th May with 576 facilities. And we ultimately, on 18th of July, we had more than 12,000 facilities registered. So this was the recognition that was given to councils verifiers and to the district verifiers in our recently held Ayushman Divas on 23rd September. Our additional chief secretary sir is felicitating them. So Bihar is also one of the states where we have, as I mentioned, we have a health system digitalization HMIS MS service provider on board. We have a contract signed, and I'm really hopeful and optimistic about the various benefits that this entire revolutionary scheme of digitalization of healthcare records is going to bring. So now probably in a few days we are going to create even more Abha IDs which are going to be created in OPDs also. And we are really hopeful and looking forward to the entire revolution this digitalization of healthcare system is going to bring. Thank you.
Thank you, Anshulji. Bihar has done exceptionally good work with respect to HPR, and the continuous monitoring surely leads to results in population of HPR. And we also look forward to integration of the HPR with UP so that we have good population of HPR. So with the permission of the chair, sir, if you allow, we have still around 23 minutes in our session. So we can keep 5-7 minutes for small question answer if we have anything from the audience. So if you have anything from the audience, you can direct your questions to the panelists also.
Thank you very much. I'm Narendra Modi. One issue which is this online-offline issue. and Dr. Sharma is also here, so I think that makes better sense. Is there a technology available that whenever poor internet connection is available, it just shifts automatically to offline, and immediately as the, so that this buffering issue does not come, the speed is not affected. Whenever good speed is there, but if it is not there, it just goes offline and you enter the data. So if that is there, I think if we can see this is part of every software we are talking about. Second issue is that there are now, technology adoption is a very complex issue. And many times we think, if I go back to my mother's time, when first time gas cylinder came, she was also keeping it covered and using it only for teaming. Today we say the new where Ujjwala has been done. Similarly, I think doctors will also require proper principles of technology adoption, and I think there may be some state level differences, probably some formative studies may be done, how to encourage health professionals to use the data, and they don't use their pens anymore. Thank you very much.
I'll answer your second question. So when we started doing this study to understand how doctors are using systems, so we went to NH, right? Narendra. I think Praveen sir was telling us you should visit one of them. So when we did talk to Dr. Devi Shetty and his team, they were able to tell us the older generation, it's also a generational thing. It's not just about the single curve, right? The older generation is very happy in doing and using a computer. And the younger generation are good in tabs. So they definitely told us, do not think that you can put a tab everywhere and get things going. So that's one of the challenges we'll always see. So what they also have done is they have an excellent system called Ladi. I think NH has already signed an MOU with them to adapt those technologies to the mainstream them to the other facilities also. The WhatsApp kind of technology, everybody is used to a WhatsApp kind of technology, right? So why can't we use a WhatsApp style of putting data entry? Whereas systems can read, AI can read. So that could be one of the solutions which we can look at. I think that's, we have been talking to Kiran also, we can also look at a medtech challenge where we can think of getting more solutions, integrating more solutions into what we have. I think as Sir has rightly mentioned, there is an highway, right? So we need to put, whether we can put an F1 car there or we can put a lorry there or a truck. So that is what we have to decide, right? So we should be able to develop those systems. Now the talk is on technology and the integration. I think that's the second stage of the part of our experience of Ebdm is going to be.
Sir, I'll basically say I'm a doctor myself, so I know that doctors are resistant to these kind of, they have a resistance to these kind of things. But what is my belief and what I've seen work also, basically if you see the Ashas and the who are the ground level workers in the health system of the state governments, if their education level and other things you see, they do better adoption of technology compared to the other people at the higher end. So simply if you can see how they are doing it basically with the fact that you provide them a simple solution and you tell to them, okay, you have to do this only. You don't need to go for 500, 600 things, and this is what you have to do, and train them properly, they can do it. I think the same will go with the doctors also. Like 95, 98% of the ailments are very simple, and they can be treated with simple data dragging options. And if we have a council kind of thing in which the console will fill in most of the 98% of the data, the doctors will just need to fill small things. And we can have some technology upgradation which can help them make it easier. And obviously after a few years, it will be all AI will fill up a lot of things. So that is how we should proceed. And anyhow, at this moment, like yesterday, when we were having an interaction, people were saying that obviously the biggest push will come from the demand side. When if people are starting to demand for it, suddenly if we increase the HMIS, if we increase the usage of EHR, and suddenly when people start to see that the EHR is such a good thing that especially people with long-term diseases, NCDs, so I think they will push the demand for it, and they will push the doctors to go for it. And obviously, there are other things which I think sir has also told, that is also very good, I think, because Andhra is leading in it. But that is how we should move ahead. The demand push is obviously better than pushing it from the top. And the second part, sir, offline wala part, I think Sharma sir is also here. Yesterday also we had a talk on this. I think there are options available for offline, but how much is NHA going to do it? How much an Aadhaar is going to allow it is the question.
Sir, I'll just add to it that we already have one offline Abha creation where which is only allowed to the areas or the programs where there is limited connectivity because of several reasons. Otherwise, sir, yes, we are going to think about it, that how to create it when the network again catches to it. Ma'am, you have a question?
Morning, everyone. I'm Vasanta. I implemented EUPA in Haryana 2014 when I working in Abdm. So there I faced the problem of internet, intranet. So offline, online mode is there because in a remote area. But we did, and all the old age doctors also supporting us to enter the data. So successfully we implemented that in EUPA. And even now I'm completed M1, M2 and ABA registration and all. We did the POC in Telangana. There also we completed that one. But I'm not facing the problem. What facing the problem is the API's integration in ABA, every time they are changing. So supporting from them, it is a little bit late. So that we have to consider, sir.
Digitization, they have easier access.
Let me try and answer Dr. Arora's question, which is basically the doctors, the reluctance of doctors in filling these things because they seem much more time consuming and problematic. So the experience which we have had thus far in a couple of months, that M1, M2 and M3, the creation of ABHA and the linking of records and sharing of records, this is what is called M1, M2, M3, that happened. So we realized that while we construct these health management information systems in hospitals, e-hospital or e-Susrut and many other systems, they are very comprehensive systems and interconnected systems. They are like SAP in some sense, enterprise grade. So what happens, you have laundry, you have beds, you have registration, you have medical inventory, and everything is, comprehensive into it. Now, maybe Apollos and maybe Max and maybe some big chain of hospitals will require such kind of thing. Even a smaller one may require. I'm not saying that they will not require. But they need capacity building in terms of using it. And sometimes, some of these times, these Sarkari HMIS systems, they are not extremely user-friendly. So, you realize that this is, I find it very difficult that either menu pe jao, us menu pe jao, ye drop down aayega, those kinds of things. So I think what is required is from the supply side, we need to create more user-friendly systems, very intuitive type of systems. After all, WhatsApp and all these programs, how have they become so successful? Because they are pretty simple to use. How have COVID become so successful? Because it's very simple to use. I mean, you just have to put in your mobile number and you get an OTP and you're good to go. You can see the certificates, the history and everything. So I think the simplicity at the front end is the key, one of the very, very important keys to adoption. And so what we are doing is, we are now actually repurposing COVID to take such the role of a very lightweight HMIS. And let me explain how we are doing it. One is that COVID, what does it do? It essentially is, on the one hand, it provides the supply side information as to where, which vaccine, what time, what cost is available. On the other hand, it provides the demand side requirement satisfaction in the sense that which hospital, what kind of things are available. So hospitals can publish, people can see, and then they can see, book, and then finally avail the services. This is how kind of matchmaking takes place, demand and supply, a very transparent way those COVID dealt with that situation. Now we can always extend COVID because look at the vaccine scene, look at the immunization, for example, for children. Now, whether it is a diphtheria or all those 12 essential immunization things, polio drops and all that. This is easily accommodatable. I mean, it doesn't require, COVID doesn't require any whole set of re-engineering except putting in the data of all the essential vaccines, their rules, their intervals, and then, it can do all the functions. It can remind parents that your first dose of polio was given this day, your second dose is due, please go ahead and get it done. And then, of course, list of all the hospitals. But there is a module in COVID which is called a vaccinators module, which is not used by people, which is used by the vaccinators in the hospital. Those vaccinators do two things. One is they identify the person, and then secondly, they inject the vaccination, and then they make a record. Essentially, that once they do that, once they make the entry saying that this person is vaccinated, a record is created. And that record becomes a part of his vaccination certificate. So immediately, that is how, on the basis of that record, you can download the vaccination certificate. This is how the whole process works. Now, what we are doing is, we are actually repurposing that COVID vaccinator module to become the doctor's front end. And then the doctors can, while they can publish their, what kind of immunization vaccines they are giving, not the COVID vaccine, but other vaccines, they can also do this function of, writing prescriptions and other kinds of things in a very simple manner. And we are actually trying to create a very, very simple, intuitive way of data entry. And there are some technologies available which are voice to text, for example, even the writings to text. Those kinds of things we will introduce, which will make things very easy. And I think that will be one of the keys to adoption. Of course, on the other side, doctors will also have to, try a little bit to adopt that technology, number one. And number two, the patients will also have to put some kind of, pressure on the doctor saying that, why don't you give me a digital prescription by which I can buy medication and other things. So I think we are working. And I think this repurposing of COVID will take place in a month's time. Hopefully by the end of October, we will be able to put it out in open, and then, we will start the immunization program. The universal immunization program will ride on this repurposed COVID. We are thinking of a name for the new entity because COVID is associated with COVID. So we are putting up in MyGov, we are putting up an ad saying that we'll give you a prize if you give us an appropriate name for this new software. So maybe all of you can participate. Thank you very much.
Sir, I would like to request you to come up to the dais, sir, please. Sir. Sir. So for this other question, sir, session, sir.
So one more question.
Yeah. 1 second. 1 second.
Just to follow up on the, already sir has explained certain aspects. Now, integration is key to the whole thing, but there are a lot of these apps which Government of India is already operating, like the Poshan app, the NCD app, the RCH. So that integration with the Ebdm is not happening. I mean, is there a way ahead for those kind of things, sir? Second, to Naveen is the question regarding e-hospital was adopted by Andhra. And you have doctor care now, which is again a local kind of a thing that you have developed. Are they operating together or they independently operating? How is it operating?
Sir, that's the beauty of Evidium, sir. They're already connected. So I remember what we did is, when I asked NIC people to do it, he actually did it one day. Sunil Bhushan is the director of NIC who looks after the e-hospital. So he was so excited that the systems could talk to each other. He has been there in this field for 25 years, 30 years. So there was a record which was inputted from a doctor care application which he could see in e-hospital. So he was so happy, and in fact I remember this, I think a couple of months back you tweeted also. That's the beauty of Ebdm, sir. I showed you what we showed you on our system. All the data, which is 104, 108, your Arogya, which are all digitized data. It's not digital data. All this data is available with our Ebdm. That's the beauty of Ebdm. It brings all the information at a click of a button or click of that. When you log in, you get all the information for everyone to see. And I think there's a talk about precision medicine, sir. This would lead to precision medicine because you would exactly have the data which would make the right choices for the doctors to, make decisions. So this would lead to precision medicine. That's the future. I think This, I keep telling this one every single day, medical innovation in India is the next big thing, and Ebdm will lead it.
I think we had one question there. Yeah.
Yes, sir.
Just after that.
Yeah. Good morning, everyone. So, as Akshay sir was mentioning, like we have offline authentication for M2, like creation of the health ID. But whereas like verification of the record or like verification of the beneficiary is also much required, because since we are concentrating on public facilities which should be in rural areas, we can't expect like 24/7 internet or like proper bandwidth, electricity and also. We have enough authentication modes for the verification of beneficiary, like in terms of by mobile application, OTP, Aadhaar, OTP and all. But all this works only in case of when we have proper internet and electricity. We don't have any offline method when bandwidth goes down or application goes down. That is one thing. And in M3, when we want to view a record, we have only one mode of authentication that we completely dependent on the mobile application. The end user, like the citizen, should be tech savvy and he should be mobile savvy, which we can't expect much footfall in the public health sector. And third ones are like, as like many audience are mentioning, like we have different portals. We are integrating the data, but we are not integrating the single sign-on kind of thing. Now, if I want to log into any of my regular day-to-day work applications, it could be finance software, banking, even now Razorpay and everyone has given a single sign-on using Google APIs and all. But even though we have unique ID for facilities, HFR, and unique IDs for HPR, we are unable to create some single sign-on for the healthcare workers and all, which could be easy for them in their day-to-day activity. Because even when we consider ASHA and ANM, they may not be much tech-savvy. They are good at their medical terms, but they may not be good at technology thing. But still, they need to remember 10, 20 username passwords, and we say them to be very sensitive, and they keep on writing in diaries and all, and they'll keep unattended also. So in order to make it more easy for them and more, once if we make easy, they can easily adopt that as well. Thank you.
Thank you. So I'll take the third question first. So a single sign-on, yes, it can be explored. We have already discussed this idea where we discussed that every patient can have their own Aadhaar IDs and they can sign on to different facility providers or healthcare providers, and they can create, when the healthcare providers and their HMIs are integrated with us, why can't a single Aadhaar ID can be the single sign-on on all their portals? So similarly, HPR and HFR also we can create single sign-ons where they can create, suppose professional IDs, they only have to create one HPR and then they can create single sign-ons from different portals from there. So secondly, I'll come to the first question that offline verification of the HFR and HPRs. But as far as I remember, the application has to be created by the facility managers or the doctors or the professionals, and then those have to be verified and then created by a different account, right? So, but then why do we want a offline verification for this HFR and HPR? Okay. 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 So for that, for offline, sir.
Itself is defined as online. You know, authentication is not really some, if you read the Aadhaar Act or any other act for that matter, in the digital world, authentication is essentially online. The question is that, you know, connectivity is the question typically. Now, if you look at the, you know, country as a whole, I do agree that there may be certain villages, certain areas where you don't have such connectivity. Maybe there are patchy connectivities, you know, in the sense that sometimes it comes, sometimes doesn't come, or sometimes you have to go to some place where you have better connectivity. In fact, in our buildings also, वो कहता है इस कोने में चले जाओ तो आपको टावर मिलेगा, इसमें नहीं मिलेगा. उस तरह का, that things are already there. But the point is that, you know, when the beneficiary is doing, you know, you can just take it as a trust, saying that, okay, this is your Aadhaar number and this is what you do, and that is the responsibility which one has to take. Authentication does not say that, you know, you have to always, you know, you can't do anything if there is no authentication properly done. Authentication cannot become an excuse for denial of services. That much is already there, and, you know, there are always exceptions provided. Any act or any law, whichever we have had, nobody shall be denied service just because he is not able to do an online authentication. However, I think things have improved much, much beyond what they were in 2009 or 10 when we started Aadhaar. At that time, people were saying there is no connectivity, there is no connectivity. That was understandable. Also remember that the data requirement for this connectivity is very little. It's just a few bytes of data which goes. It's a textual data. It's not some images are getting. In fact, even when you do face authentication or you do fingerprint authentication, there also it's not the raw image of the fingerprint which is going to UIDAI. It's only the minutiae which is actually just a small textual data of a KB or so. That is what it goes. So the problem is not as prevalent as one would like to believe. But yes, there are problems, and in those situations, exceptions must be applied, and people should not be denied service. That's the only point I wanted to make.
Sir.
Dr. Ashish, actually, my question is, we have already lot of digital data in different portals, in different ID against one person in different portals. And we are not using the digital data available with us. Like we have some information in IHIP, some information in Nischay, some information in Poshan, lot of information in ICMR portal. For UP, we have our own portal. So there are lot of data available for public to make public decisions, but we are not utilizing that. So Ebdm, we are focusing on EHR, or we will include the public health also in this portal, because the segregated data is present in various portals. We are not joining them. We are not using them for making public decisions. So in Evidium, are we are going to do this, or we again taking this in silo?
Abdm necessarily harps upon this. Necessarily has to be done. Integration of different wherever data is maintained in silos has to be integrated on a single, so that those different silos can talk to each other in a standardized format. And then the data becomes interoperable and then usable to different stakeholders, doctors or the facilities or even the policy makers. So has to be done.
Without geotag data, how we can use for public health?
Without geotagging, some of the data might be having geotagging, but other data might not be having.
When sir Abha is not having the geolocation, then any record,
the record is created wherever the record is created, there geotagging
will not be located to any area. If any record is stored against the created Abha at present.
Sir.
Mohit, so the point is, the vision is very clear, right? I think Akshay and sir, time and again everyone is talking about this only. It's very clear that it has to be integrated. I told you, e-hospital has been implemented for a long, long time. The moment they become Ebdm compliant, they were able to exchange data. And what we have done in AP, all the data, what you are talking about portion, we only collect data. So why can't we push the data in our own systems? So that's what AP is doing. NCT said the reason we have 3.3, in fact, we have 3 core CR data already EHR'd, ready for putting into our database. How are we able to do it? Because all this data, we think it's useful. So we made it Ebdm compliant from day one. So the vision has to be clear when you start your journey. So when we knew that we have to do it on the Ebdm platform, it's how it will be done. And I think Akshay had clearly mentioned that's a future. What to see yesterday, I think if you had attended the last one, it was very clear. It is not about digital healthcare. It is healthcare which is put primary using digital, right? So this agenda is very clear. It's the healthcare which is at the first and foremost of our, objective. So that will be taken care through a digital system. So that is very clear.
So I think we need to have the last question now.
The suggestion is that we have lot of data already available where the students do research. So there are big cohort studies happening, big research organization, ICMR is one of them. So those data should be placed somewhere in Abdm. I didn't have the chance to listen whether there's an option for that. And probably that will give way to big data research, secondary databases which will be created, will be very useful for health research. So that was my suggestion. And my question is that in the country, nearly 70% of, 60 to 70% of healthcare, outpatient care is provided by private players. So how much ABDM plans to engage with the private sector in the coming times? So do we have a clear roadmap for that or, yeah, thank you.
I will answer, Akshay.
Sir.
So your question is, that's a future. If you see our objective when we made the presentation, the medical research is the future of AVDM, right? So how do you bring this medical innovation through medical research? So there is also a talk in the NHA, which I think sir has also agreed. There will be a wing and the data will be given. I think there was also a discussion on the data panel. If there was also a discussion where, see it is, I think Rama madam was mentioning it in our data panel when she was very clear, the data has to be shared in a way that it's useful for research, right? So that was, I think that's the clear, one of the clear objectives which we have seen out of the Arogya Manthan for the last 2 days. I think when the team is going to talk to the minister or present before the minister of IT, this was one of the things which would come up. The second part which we are talking about is, I think the engagement, if you see how did COVID win the entire fight, is that this is the first time the government infrastructure, it's a big lesson. I think this has not happened in the last 10 years or so. First time the COVID platform could give data to people to use it, be it integration with Paytm, be it integration with any other player to do it. That itself is I think it's the principle or the policy which has been clearly established. So which means that any private operator and the repurposing of the COVID will also help, putting these private players on board. See, he is not, as I told you in my speech also, they start, I think there is a starting, problem. Once they start, they are very comfortable using this application. We have partners like Eka Care. If you see it in the dashboard, I think they are logging in 3rd or 4th in the entire EHR recorded. So that is itself is a clear message that the private operators are ready to put EHR onto our platform. That's a clear way of going around.
Would you like to add?
I'll just add on to what Naveen said. I mean, it is what kind of incentives that we create. I mean, why is everybody so keen today to get a PMJY card? Because there is an added benefit to that. Now, what kind of incentive can you create for the private doctors, nurses, establishments today? So, for example, Karnataka, as I was mentioning in my talk, all our empaneled hospitals under the PMJY, if they have to get their compensation reimbursement, they need to have these IDs. So we tell them that you are recognized in the whole AB architecture with these identifications. Say they want to take up organ transplantation and they want those licenses. Then we create this as the unique ID and then tell them that yes, now you are on board, we'll take it ahead from here. So probably these kind of systemic triggers if we have in the system, then they feel that it is part of the routine rather than questioning later. So slowly over time, I'm sure that they will recognize the larger goal of the government, larger goal of NHA in terms of what this integration means, and they will come on board. But the journey has to be gone through for every state independently. I don't think we can have a magic formula at the top with NHA telling us and it translating on the ground. Thank you.
Sir, would you like to add, especially the incentive part and how we go for it?
India is the country, and I think the only large country in this world which has created unique digital identities. Every person in this room hopefully will have his Aadhaar number. And the design of Aadhaar is it's a random number and you can't really do much if you know my Aadhaar, for example. And I even went to challenge everybody saying that this is my Aadhaar number, do what you can do to me, and nobody could do anything to me. And believe me, you provide your Aadhaar number to everybody, and If anybody who knows your Aadhaar number could do any harm to you, you could not probably be able to sleep in the night. Because you will think, मैंने 1000 लोगों को दे दिया है, उनमें से कोई भी रोग आदमी निकल के मेरा नुकसान कर देगा. Nobody can do anything. However, somehow or the other, this has come to be branded as some secret, number, which should not be disclosed, which should not be put in a database, and all kinds of stuff has happened. Vaults have been created, Aadhaar Data Vault, ADV as they call it, many of you may be knowing. This is all, I think, it's not required, honestly speaking, because there's a professor in IIT Kanpur, Professor Manindra Agrawal. He has proved it like a mathematical theorem that disclosure of Aadhaar number or Aadhaar number itself does not increase the digital vulnerability of anybody. But here, this is not a debate about Aadhaar. What I want to say is, one of the problems which has happened in actually ensuring such kind of citizen-centric view, one of the objectives of Aadhaar was, there were two objectives. One was citizen-centric view of benefits and citizen-centric view of all other kinds of problems, what kind of issues he's facing with. That's one part. Second was eliminating duplicates and fakes from the system. These are the two objectives of Aadhaar, and you can see it in the strategy document of Aadhaar. And of course, third was to provide digitally verifiable, unique identity to each resident of this country. Now, if you have a common identifier across databases, then in that sense, you can do better research, you can do better kind of, bad word is profiling of individuals, but I don't think every, citizen-centric view of, let's say, disease or any other kinds of things could be construed as profiling. This should not be. And there are public health issues. We are dealing with public health issues. That is why we have created what we call Ayushman Bharat Health Account. It is not an identifier. We don't call it ID. We call it like an account around in which you can put all your, deposits like medical records. So that's how, and once you have multiple databases and this problem of, common sort of sign-on, single sign-on and other kinds of things, all data talking to each other, as Naveen was saying, they will talk to each other if there is a common identifier. If you don't know that R.S. Sharma in this database is the same R.S. Sharma in the other database, you can't really, unambiguously connect them, because they may be two different people altogether. So therefore, I think the common identifier makes it easy for databases to communicate with each other. And of course, that communication has to be a regulated communication. Communication cannot be just sort of haphazard communication. Anybody can, kind of do things. No. And that, I think, one has to realize, because if you don't have a common, in fact, COVID, for example. Now, COVID, some people used one mobile number and created one vaccination, vaccination one. And then they used, for next vaccination, they used some other mobile number. And then they created another vaccination. And then they were saying, oh, why was I not connected? This is not my first vaccination, my second one. Arey bhai, aapki galti hai. You should have used the same mobile number. It's not my job to connect you to, or maybe you do use two identifiers, and one you use passport, another you use driving license, third you use Aadhaar. I can't do anything about it. So this is not a, now then, we created a utility whereby you could merge these two vaccination records. If people were knowing that this is my mobile number and this is what I use, of course you can use one mobile number to multiple records, that's not a problem. But you should not use two mobile numbers on the same record, because then it creates two individuals. So essentially, I think this discipline slowly will come. And we, for example, we designed a very simple way of entry into CoWIN, because initial idea was, why don't you have username and password for each individual? मैंने कहा भाई 130 करोड़ लोग username password कौन याद रखेगा? कितने username password आप याद रखिएगा? So then we came up with the best username password is a mobile number and OTP. And no serious breaches have happened during this period. I think it's a simple thing. So what you do, you create your Aadhaar account, then your Aadhaar account is linked to your mobile number. Next time onwards, you just put in your mobile number and your records will come, finished. You don't need to remember in Aadhaar number. Aadhaar number will work at the background just to collate and connect the databases which are required. And it's not, you don't have to remember that 14-digit number. That's how it's going to work. Thank you.
Thank you, sir.
Sir, we are already exceeding time, so I'll just use this opportunity to distribute some awards for the top performing states and UTs. Uh, uh, we have, sir. Yes, sir. Sir, please, no, sir, please, sir. So, first of all, top performing state and UT who have achieved maximum percentage saturation population of private health facilities in HFR and have reached more than 90%. So I'd like to call upon Dr. Iftikhar Ahmed Chaudhary from the state of Ladakh. Okay. Sir, so I think somebody else has been allowed.
Sir, I can do the announcement.
Kansha, you can announce?
Yes.
Please.
So it is a matter of great honor and pleasure to appreciate and reward the hard work put on by the states and UTs while implementation of Ebdm. Under the top performing state and UT achieving maximum percentage saturation in the population of private health facilities in the Health Facility Registry by 19 September, we would like to reward the state of Ladakh. I call upon the stage Dr. Funsuk Norbu from Ladakh to receive this award. Now I would like to call upon stage Dr. Khushbu H. Rathod from Dadra and Nagar Haveli and Daman and Diu to receive the award. I request R.S. Sharma sir, CEO NHA, to do the honors. Under the top performing state and UTs achieving maximum percentage of saturation in the population of doctors and nurses in health professional registry by 1919-2022, I would like to call upon the stage Sri Anshul Agarwal from Bihar to receive the award. I request Gyasuddin Sir Ahmed, Financial Advisor, NHA, to do the honors, please. Now I would like to call upon stage Dr. Maninder Walia from Chandigarh to receive the award. I request R.S. Sharma sir to do the honors. Now I would like to call upon stage Dr. J. Ramesh from Puducherry to receive the award. I request Dr. R.S. Sharma sir to do the honors. Next, I would like to call upon stage Mr. Mag Nongingpur from Meghalaya. I request R.S. Sharma sir to do the honors.
Thank you so much, sir.
Now I will request CEO sir to kindly facilitate our panelists.
Facilitation of the panelists.
मैंने काट के दिखाता हूँ वो साउंड
Mr. Anshul Agarwal, SMD, State of Bihar. Gyasuddin Ahmed sir, FA National Health Authority. Naveen Kumar sir, Special Secretary Government of Andhra. Manan Akhtar sir from the state of UP. No, thank you so much.
I thank everyone here. Now we will be having a tea break. So we will be continuing with the session at 11:30.
Thank you, sir.